on this episode of A Tale of Two Hygienists.
There's a lot of myths and misconceptions that come along with infertility. I think there's like a thing that we think that women experience infertility more than men do, but actually 1/3 of cases are women, 1/3 of cases are males, and 1/3 of cases are both partners. When your immune system's overactive, like it can actually impact like the implantation of the embryo. There's research that shows that women with endometriosis are 57% more likely to have gingivitis or periodontal disease. P. gingivalis is significantly more frequently detected in the saliva among those that are having trouble getting pregnant. So all of these, things like diabetes, heart disease, Alzheimer's. So really just, I think, comes down to that inflammation and immune overdrive.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists. I'm your host, Andrew Johnston, and you are listening to episode number 440 with Jessica Woods. In this week's episode, we dive into infertility and dentistry. We talk about things you need to know for yourself, but also things that your patients might be experiencing, some conversations that you might be able to have with them, and then just understanding how some of these medications that they might be taking will impact their oral health and what kind of education and coaching that you need to provide for them. Jessica has so much more information. All these episodes are just way too short. So be sure to reach out to her if you have any more questions. Then next week, Annie and I welcome in Kimberly Erdman, and we talk about forensics. Forensics is such a hot topic. It's always full up in all the courses that I see at the conferences. Kimberly worked identifying remains primarily from servicemen and women, and then also other people connected with the government. We dive into the process of identifying remains and what kind of hygienist this job might be suited for. So be sure to come back for that episode because it is freaking fascinating. Also, last announcement, RDH Under One Roof is officially 30 days away. And from the last update call I heard, we are tracking to have even more attendees than last year in Nashville. They opened up lots more space, but you have to register right away if you want to make sure that you have one of those last slots. I believe the promo code podcast30 is still active if you wanted to use it. And if it is active, it'll get you $30 off of the full conference registration. So my advice, if you're undecided, if you're on the fence, just commit. You're going to enjoy the time. You're going to enjoy the experience. You're going to be happy that you went. So just commit right now. You're going to do it right when you get off work or whatever's going on today. And that's it for this week's intro. Thanks to everyone for listening, and enjoy this episode with Jessica Woods.
A tale of two hygienists.
Listeners, you are in for a treat today. We are joined again by Jessica Woods. Jessica, welcome back to the podcast.
Yeah, good to be back.
This, we were saying off air, we both had listened to our last episode they did on cardiology. I want listeners right now, go back and listen to that one because there was a lot of really good discussion on assessment and detection and things that I think that we're just not doing. I think that we can easily be the front lines for our doctors with our patients with doing things that don't hurt our patients. They're, oh my gosh, we're going to edit this part out.
Invasive.
Thank you. They're minimally invasive. Actually, we're not going to edit that part out. We'll let Andrew look stupid. That's fine. But they're minimally invasive. And, it's just, I think there's things that we just don't think about that's within our scope that we just never do. So listeners, go back and listen to that one. But man, just so happy you're back. This is going to be great. Annie, welcome to the show again, co-hosting again.
Thanks, Andrew. I'm so happy to be here and excited for this discussion today.
I'm excited too because we're going to talk about infertility. And I think that when we talk about infertility, I think that people are going to be like, okay, well, how's that dentistry? How is this even going to come back to this? But Jessica, that's why you're here. That's why you're the expert on this. You're going to help us figure this out. So I would maybe let's start off with how did you get started in like researching and talking about infertility?
Well, a lot of my like crazy ideas for topics usually come from being personally impacted by them.
Yes.
Or having like a personal interest. And I'm just kind of like, oh, well, I think this is cool. Hopefully other people find it interesting and beneficial. So I guess I'll start there. I mean, I really didn't think a lot about infertility before I, experienced it. I think probably a lot of people can relate. In your younger years, you spend so much time trying to prevent pregnancy that when the time comes where you're wanting to build your family, you think it's just going to be like, honeybees and rainbows and all of that. And it's just going to go. And unfortunately, in my case, that is not how it was. So I had a dear friend who I lived in Nevada. She was Miss Nevada at the time, and she had a pretty unique experience in fertility. She talked a lot about it. And so when I was personally going through that, I really leaned into her because I feel like a lot of people suffer in silence. And as we get into the prevalence of this, it really impacts a lot of people. So it's going to impact your friends, your family, your patients. And so I think it's really important as healthcare providers to be knowledgeable about it. And then I was like, my world kind of revolves around dentistry. I'm like, how do I bring these two worlds together? And so I started digging deeper, and there really is a lot of emerging research on the link between oral health and the impacts that it has on fertility.
I'm super excited. Can we talk about the stigma first, though? Because I feel like there's one of like two feelings that people feel like when they have infertility issues, and I think it's maybe different for men than it is for women. Our audience is predominantly women, so maybe we'll talk more about that. But what is that stigma? Is it founded or is it unfounded to have like, I'm not good enough, my body's broken? Like, what is the thing?
Yeah. So, I mean, there is a huge mental health element of infertility, and I found that out personally. I think it is like supported. I do a lot of advocacy. I sit on a board for infertility nonprofit here in Nevada, and a large portion of our work is support groups, mental health support, all of that. I know I can share personally, and I've had a lot of people in our support group echo what I felt. You feel like your body's broken. You feel like your body's failing you. Like, women were intended to have babies, and when your body isn't doing that, you feel like, there's something wrong with you. There's this like innate, like biological thing of like wanting to procreate and all of that. So yeah, there's definitely a huge mental health impact. And I do some speaking on mental health, so maybe we'll talk about that on another episode.
Yes.
But that is from other life experiences that I've had. And so, that kind of led me down, I was struggling. I was having a really hard time. And I mean, people like, I'm just going to throw it out there, sex, sperm, whatever. We're going to talk about these words that people don't like to talk about. And so it's like a downer topic. It's like, it's like,
you're not going out
by
and
the
going
way,
to the club and being like, hey, let's talk about my sperm. We don't talk about that as guys. We're like, hey, let's talk about my sperm count here. Let's talk about motility. Let's do these things.
Yeah, exactly. So then you find yourself like, suffering silence, and, it can actually cause a lot of strife within your relationship too, because like, now when you're trying to procreate, it kind of takes the fun out of it when you have to like time everything and take all these tests and do all this. It's like, wow, that's really not that romantic anymore.
It's like robots now. You're like, all right, like this is...
Yeah, it's like, okay, sure. I'm ovulating in 36 minutes, so get ready.
So very planned. So piggybacking off what you were saying, connecting the two worlds, right? The fertility world and your oral health world. How can we as oral healthcare providers help disseminate some of those stigmas and help our patients in that space?
Yeah, well, I think maybe just taking a step back, what is infertility? So, there's a definition by the World Health Organization. What it's characterized is by 12 months of regular unprotected sexual intercourse. If you're, getting older over the age of 35, that goes down to about 6 months. So we know that, age impacts infertility. So just understanding what infertility is some of these organizations have recently updated some of their definitions to be more inclusive. We're seeing a lot more same-sex couples trying to have kids and transgender and all of those things. So obviously for biological reasons, infertility impacts them as well. So we're seeing kind of a little bit more of an inclusion movement in the fertility community. I think there's a lot of myths and misconceptions that come along with infertility. I think there's like a thing that we think that women experience infertility more than men do, but actually 1/3 of cases are women, 1/3 of cases are males, and 1/3 of cases are both partners.
Oh, interesting.
So
Like they're not compatible, is that what we're saying?
Yeah, or like you both might have something going on or compatibility. Yeah. So typically women are the ones that seek care or maybe talk about it a little bit more. I mean, I know it was hard for me, but I've talked to some men too, and it's very emasculating, like, because you're supposed to be like big and strong and have all this sperm, and it's just like never happening,
Yeah, like we're going to have all of the children and we're repopulate the earth. That's what our job is. And,
exactly.
Yeah, I mean, and let me ask this. So they're talking about the myths, though, and you mentioned it earlier. Like we go through, periods of our lives where we're doing contraceptives and things like that. Just like, is there any truth to the fact that some of these things that we've been doing to make sure we don't get pregnant earlier are having a lasting impact?
Definitely. There is a lot of, we're messing with our hormones. And this, a lot of fertility comes down to hormones and having balanced hormones. So, long-term birth control can impact it. Other environmental factors, our food, we have a lot of chemicals in our food, fragrances, all of those things are hormone disruptors. And so, we could spend a lot of time on this, all the environmental factors that play into infertility.
Man, it just seems that there was a time, it feels like, where infertility wasn't such a problem. Is there, again, staying on this like myths and misconceptions, is that true? Like, is it getting worse? Like, is the prevalence getting worse now than ever, or is it just no one ever talked about it before?
Actually, the prevalence is getting worse. So last year, the World Health Organization updated their statistics. So when I first started doing advocacy in this space, we were saying 1 in 8 couples were affected by infertility, and now the data shows 1 in 6. So It's a growing problem. So think about, you see 8 patients a day, at least one or two of your patients is probably going to be experiencing some form of infertility. And, there's a broad spectrum of it. I think a lot of people, when you hear infertility, they typically think, IVF and, these more invasive treatments. But like my case, thankfully, I did not have to do IVF, but I had a lot of hormonal imbalances. And so it was a matter of, finding out what those were and then managing those. And so just because, you start to have fertility issues doesn't always mean that you have to, have IVF or use a surrogate or adoption or what have you. There's less invasive ways of treating it, and, different. Everybody's case is so different.
Can you speak into that a little bit more as far as what treatments look like? I know that's a large topic, but elaborate on that a little bit more.
Yeah, and I think that's kind of a good lead in as well for oral health professionals because, different levels of treatment, some it's just medication, sometimes it's surgery, so things to understand. So as a whole, it's known as ART, assisted reproductive technology. And so there's a lot of modalities that fall underneath that. So it can be as simple as assisting just with ovulation. There's medications that can do that. There's IUI, which is intrauterine insemination. And so basically it's where the doctors help you, or, reproductive endocrinologists specifically, where they'll actually take the partner's sperm, they check it, make sure everything looks good. They wash it so there's a high concentration. The female may or may not take some medication, and then they do some timing and they basically get the sperm right where it needs to go. So it's not done during intercourse. And then we have IVF, which is, a little more invasive, and it's a couple step process. So with IVF, typically, they'll do some ovarian stimulation. So some medication to help stimulate your ovaries, make sure that you're ovulating, get a lot of follicles, and then they'll do an egg retrieval. So it is a surgical intervention. Typically, you have to have some sort of anesthesia for comfort. and they'll take those eggs, or they'll extract the eggs, so to speak, from the woman. And then they take those eggs to a lab and just test them for quality. And then they'll join it with the sperm and then allow those to incubate in a lab for a few days. Some of those embryos will make it, some will not. They'll take, the best looking ones, and then those are the ones that would go in, be considered for transfer. So there's different ways of doing a transfer, but basically they'll, take one of those embryos and put it into the woman, implant it into the uterus, and then the hope is that you'll get your positive pregnancy test. And then, it's very expensive, and I think that's where the mental thing comes in. We know in oral health that there's a big access issue, and that, oral health kind of gets left behind a lot with other areas of medicine, but fertility is the same way. A lot of insurance does not cover this, and it's a medical disease, but it's not always looked at that way. Just how oral health is, sometimes viewed as a vanity service or what have you, but we know that that's not the case. So, in most cases, these modalities, are successful, but for a percentage of those experiencing infertility, that's not always the case. And so there's other things like surrogacy. We use that as a common term, but there's actually traditional surrogacy. And that would be when the surrogate is using her own egg and then the sperm of one of the biological parents. So typically that's when there's an egg quality issue in the female. And then there's gestational carriers or gestational surrogacy. And this is usually what we see, where it is the biological mother and biological father's, egg and sperm put together, and then just someone else carrying that pregnancy. And then, there's always adoption as well. That's another way to build families.
I'm just sitting here thinking about we talked about the mental health component with infertility itself. And then I'm thinking about the mental health component with just going through treatment alone. And there's so many treatment options, which yay for modern medicine. But it's so much though. So much stress, I feel like.
Definitely. And when you're going through, like I said, timing is very important. Your life really gets put on hold. When you're going through IVF, you're constantly injecting yourself different hormones, different things, it really takes a toll on your social life, your mental health, all of that.
I feel like IVF is the one that is talked about, whether it's through media or what we see, even in the dental hygiene forums and stuff. A lot of people have gone through IVF. How often are the other modalities used in comparison?
Yeah, so I'm definitely not a reproductive endocrinologist, so I probably can't pop off actual statistics, but sure. In some cases, they'll try less invasive, try medication, a couple cycles, see if that works. Maybe they try some IUI, see if that works before they go to IVF. For my particular case, I was a little bit older once I decided I wanted to build a family, busy building my career. And because of my personal condition, they were we'll try to balance your hormones, but we don't think you're a good candidate for IUI. The success rate is, I think, I work closely with a reproductive endocrinologist. I think the success on that is around it helps by 20% or something. So fairly low. But a lot of people do it because insurance will cover. They may cover that, but not IVF. So they, try to use their insurance benefit and at least try that. Or, IVF is very expensive. It's, roughly for a full cycle of IVF around $25,000 to $30,000 out of pocket.
And that's not guaranteed, right? So
it's not
no guarantee.
No. Yeesh. The medications, I'm sure you don't have a list in front of you of all the medications that are out there, but I'm thinking about the hygienist is reviewing the medical dental history. Either it's an outdated form that doesn't have anything on there for these mark yes if you're here, mark yes if you're here, no there. What medications could we be on the lookout to see if there's some infertility, either issues and or treatments going on?
Yeah, so there's a few things. So sometimes even oral contraceptives like birth control are used during infertility. And so we're usually pretty well versed in knowing what, some of the oral implications are of that. But there's things like, so Clomid is a very popular one. That's like, actually men or women can take that one. It does help with sperm quality as well. So Clomid is a popular one. Letrozole, it induces ovulation. That one has, pretty popular. And then some different hormones. So there's like FSH, which is like follicular or follicle stimulating hormone. Even aspirin can be used as well. And then estrogen, progesterone. And we know, when a woman is during her menstrual cycle, we see a change in the oral tissue, increased bleeding, increased inflammation. Same thing with pregnancy, because we see an increase in all of these hormones. So all of this, when you say it, you're like, oh yeah, it makes total sense. But it's not something we necessarily think of all the time. But yeah, so in my case, I had to take progesterone. I had really low progesterone, and I had to take it all the way through my pregnancy as well. I'm like, oh my gosh, I feel like I still haven't recovered. Like, I'm like, my gums are like not the same. It's odd. But, and then there's a lot of supplements as well, because there are supplements that help. And then there's also a lot of people who, maybe can't afford infertility. And so they're trying to take natural supplements that will balance their hormones. Some of the common ones is one called Vitex. And so it helps improve female fertility. And then myoinsitol, so that specifically people have like PCOS or polycystic ovarian syndrome. It helps to regulate ovulation and reproductive hormones. It also helps to improve sperm quality. So all of those are available over the counter. And so it's important to ask about supplements too, because a lot of times our patients, they're like, oh, they don't view it as a medication, and that, obviously has impacts on our body and our mouth.
Let's take it into the direction of patients now in the chair. What are some of the things that we're going to see because of the medication and or the treatments that are kind of manifesting in their mouth?
So, like I mentioned with, pregnancy or menstruation, we see, increased inflammation, bleeding. I think where fertility really plays an impact is untreated disease. So untreated periodontal disease, untreated caries or cavities. So like I've been really trying, I'm actually going to probably submit an abstract to the American or the association, that does, reproductive medicine, and maybe do a session there, because these patients should be seeing their, dental provider before undergoing these treatments, and make sure that they don't have any, untreated disease. So just like, any other chronic disease, we know that it causes inflammation in the body. It sends your immune system on overdrive. So in women, when your immune system's overactive, it can actually impact the implantation of the embryo. There's research that shows that women with endometriosis are 57% more likely to have gingivitis or periodontal disease. P. gingivalis is significantly more frequently detected in the saliva among those that are having trouble getting pregnant. So all of these, things like diabetes, heart disease, Alzheimer's. So really just, I think, comes down to that inflammation and immune overdrive.
That's a good point, because I think that a lot of times we always talk about, and this is where dentistry is broken, if we're all being honest, we're always trying to treat something after it's happening. And this needs to be addressed well in advance. We just did, I won't say who it was, but I sat through a really good course about exactly this, where they were talking about how if we're not taking care of our oral cavity, preemptively, then they start getting into all the cardiac risks and all of the, risks with diabetes and all the things. They did talk about, pregnancy as well. That's just kind of our responsibility. I think that we got away from that. I don't know if that's just the model of dentistry anymore, is just let's polish them and get them out the door, or, what's going on. But we just need to do a better job, I think, as healthcare professionals. Well, do you all feel, this is actually for both of you, do you feel that we're empowering our hygienists to be proactive?
I think it's when we start talking about the correlations with periodontal disease and leaving untreated disease in the mouth and systemic conditions, it's for us as healthcare providers, it's well, yeah, that makes sense, because there's so many other connections with all these other diseases. But I'm wondering too, if we're not empowering our healthcare providers or oral healthcare providers, because maybe they're not as confident or comfortable talking on this topic, aware of the different implications. So maybe some of the questions that need to be asked to patients aren't being asked. So I'm wondering that too. We talk so much about diabetes and A1C and cardiac conditions and taking blood pressure, but are we really talking about infertility as much as we should be?
Great question. Yeah.
Yeah. And I mean, you see the prevalence of it,
Absolutely.
It's getting up there with the prevalence of some of these other conditions. But I think it's hard, competing priorities with, the hygiene visit. You only have 60 minutes if you're lucky.
Yeah.
And it's like throw all this stuff in there. But yeah, I definitely think there's like a place for it in your motivational interviewing, or if you, see people of childbearing years, but I get you're like, oh, how's your body doing? Like, what's your sex like? But we don't. Like most people aren't really like talking openly about all of that.
Well, and honestly, I feel super uncomfortable with that conversation with if I have a woman in the chair. I understand that I'm a healthcare provider, but any more of those lines are so blurred that you have to really be careful about how you act and how you behave. And any slight misstep is going to hurt someone's potentially, relationship with future, care providers and things like that. So like, we have to take that responsibility seriously. I do want to ask, like, this is a random question. We can edit this one out if you don't have the answer. I feel like those manifestations and the things that we talked about are really things that we talked about with women, but I didn't really hear so much of you have a male that's on medication. Are they also coming in with gingivitis and periodontitis and the things that are correlated, or is that a little bit different? Or they're not affected as much?
From an oral standpoint, probably not as much because, I think women, with their menstrual cycle, they, things are like changing so much. I mean, men, whether you want to admit it or not, you guys have a cycle too, throughout the month, and you guys have changes.
I think my wife would agree with you on that one, yes.
But, some of the signs in male factor would be like abnormal hair growth, male pattern baldness. Some of those things are impacted by, typically we see balding with high testosterone, low libido, which you probably aren't comfortable asking your patient about, but things like obesity when men are over the age of 40, a history of STDs. We do ask about STDs typically on our intake forms. If they drink, smoke, or have a history of that. So all of those things can play a factor into there. But yeah, it is kind of like. Can I
ask? Would you really ask? How would you ask that guy? Like, hey, is your sex drive low? Like, how do you ask that question?
I know. And like a lot of people just think like, oh, I'm getting older. It's like normal, but not, just because it's common doesn't mean it's normal.
I think too, like I don't know directly how I would ask a patient that, but I think trying to bring awareness around it too, because like you said, some patients just brush it off as, oh, I'm just getting older, but offering what alternatives could be going on or what other things could be contributing to it too, because I think sometimes patients just don't even think that there could be something else. They don't even consider what else. They just don't know.
Yeah, and it is a delicate topic because on the flip side, if you have somebody who is going through infertility, it can be so triggering for you to ask them, like,
for sure,
like I know for me, it's like my family's like, oh, when are you guys gonna start having kids? And like they didn't know what we were going through, and it's like, can you just leave it alone already? Like, it's like that thing, like, when are you gonna get married? And then once you're married, it's like, when are you gonna start having kids? And then it's like, even after I had my daughter, it's like, when are you guys gonna have another one? It's like, I have like PTSD from the first time around. Like, can you drop it? So, I mean, it's a really tough thing to like try to uncover information to help your patient, but also be delicate in the process. I know it's like no one size fits all, really.
The verbiage you use and everything, and right. To just be delicate with that conversation. And like Andrew had mentioned, we don't want to ruin any relationships, but trying to do our responsibility as a healthcare provider and provide that comprehensive level of care, that's challenging.
True. I mean, I think, just compassion goes a long way. I know,
Absolutely.
There's been people who, said things to me, but, if they're like meanwhile and what have you, you kind of just got to shrug it off. But it is important because, it is recommended that, if someone's going through IVF, like once they have their transfer, that you, just like pregnancy, you hold off on radiographs during that 2-week wait between when they have their transfer and when they hopefully have their positive pregnancy test. So it's important to know that. So, there might be a way at that point when you're taking radiographs to say, okay, add that in, just confirming that you're not pregnant or undergoing any infertility treatment. That might be a nice way to kind of plug that in there. And then the same thing too, if they're going to be undergoing fertility treatments, they should wait at least 2 weeks following like SRPs and things like that. You want to allow for some healing and, inflammation to improve. So that might be a thing, like, if you're doing SRPs of someone that's of like childbearing years, you might have that in your postoperative instructions, or have a way where you're kind of just like objectively like adding that in, where like you're kind of blanking it in, you're not like personally directing it at them. I mean, just a thought.
No, I love that. I think
that's great.
I think that time doing the x-rays, and even if that's name on their radar, just normalizing someone asking you about infertility, getting that out. If you ask every single patient, like it's a male or female, honestly. And so that you hear it more in like the real world scenario, it's not going to be weird. It's not going to be a stigma anymore, hopefully. Jessica, you have so much great information. If people wanted to either reach out to you or they wanted to, what was the name of the foundation that you work with?
I work with Nevada Fertility Advocates, but there is a national organization called Resolve. So it's resolve.org. They have a lot of great resources on there about, talking to loved ones that may be experiencing infertility, where you can find resources. If it's something you're interested in advocating for, they have a really robust program and website. So I would recommend going there.
If they want to reach out to you personally, how can they find you?
Yeah, I'm on Instagram. I'm executive RDH. And then you can email me. I'm jessicawoodsrdhap@gmail.com.
You'll be back again probably in just a couple months, talk about the next topic, if that's all right with you. Thank you so much for being here.
Thank you so much, Jessica. Your wealth of information.
Thanks for having me.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.